Firstly, I'd like to thank the SMA for inviting me to present at this symposium related to evidence-informed practice for patellofemoral pain. Secondly, I want to really apologise to everyone for not being here in person this morning. I'm actually quite disappointed to miss out on hearing Bill, Kay and Natalie present. I'm sure it's been a great session so far, and I'm sure it'll continue to be great as we go into question time, which I happen to be able to escape. So today we're talking about running retraining, and in particular related to patellofemoral pain. So the first question we need to ask, well, what is running retraining? So for me, it's identifying any theoretical or abnormal running mechanics which might be contributing to tissue overload. Now, those theoretical running mechanics don't always have to be abnormal. So we might have someone who's got, let's say, 10 degrees of hip adduction, which is considered relatively normal. We might be able to give them some running retraining cues with patellofemoral pain to reduce that amount of hip adduction to 7 or 8 degrees, and that's enough to reduce stress on the patellofemoral joint in order to reduce their pain. Secondly, what we need to establish is whether those running mechanics can actually be altered. So if we've got someone with a structural reason that they may have excessive hip adduction, let's say femoral anteversion, then we don't want to try and change that if it's unable to be changed. We'll potentially cause more problems than what we solve. And then the third thing for us to think about is how can we facilitate those desired running mechanic changes. So if someone has a lot of deconditioning as a result of chronic pain, there's probably going to be a lot of strength conditioning work we need to do in conjunction with our running retraining in order to make that easier to happen. And what we need to do is encourage maintenance of the change and encourage motor relearning principles. Ultimately, we're changing the path of least resistance. Anytime someone tries to change their running mechanics, it's always going to be more difficult at the beginning, but as we continue to practice it and possibly bring in some adjunctive interventions, it's going to become easier and easier to do, and eventually that will become the way that that individual runs. I liken it to trying to change a golf swing or trying to change a tennis stroke. It's no different to that. So what are some of the common biomechanics that we think might be linked to patellofemoral pain? So if we look more proximally, what we can consider primarily here is thinking about our contralateral pelvic drop, which might lead to an increase in the amount of lateral stress through structures related to the ITB, and that might lead to some maltracking. Hip control in particular, so thinking about hip adduction and internal rotation, and that femur rolling underneath the patella, but also thinking about knee valgus on that front. In a sagittal plane, we need to think about how much knee flexion that individual gets, because if they get excessive knee flexion at mid-stance, and that's going to lead to an increase in patellofemoral joint stress. If they get a limited amount of knee flexion, particularly on foot strike, that might actually lead to more patellofemoral joint stress, because that's where we know that there seems to be the most patellar maltracking occurring. If we go distally, then we can think about foot mechanics and potentially foot pronation, although it's probably not a big focus in patellofemoral pain, because unless it couples with what's happening more proximally, then it probably doesn't matter. But also thinking about foot strike pattern, so if they're really heavy with a heel strike, then that's going to mean we can't take much load or absorption distally, and usually that will be related to an overstride. So if you look at the still frame here of this runner here, we can see a classic overstride running pattern, which means we're not going to get any absorption at our foot and ankle. Our knee is relatively straight, which means there's more load on the patellofemoral joint, so we're going to get a lot more pressure happening there and a lot more increase in load just because we're landing further away from our centre of mass. So I like to use the analogy managing the risk, and I use this for all biomechanical concepts, so we'll talk about the injured runner now. So number one thing that we can do, and the safest thing we can do, is think about how can we reduce the amount of load that that individual is undergoing. So for a runner, possibly really simple to reduce their training loads. However, we know runners don't always like to do that. Now that's quick and that's easy to do. The second thing that we can think about is how can we improve their capacity to attenuate loads. This is often where strength and conditioning work comes in. Relatively easy, relatively safe, but does take some time to enact and take some time to develop. And then the third thing to think about is, well, how can we shift the load away from the area? Now, if we shift the load away from the area, this might not mean the load disappears, but it just goes to another structure. So we need to really think about how that individual might respond in terms of other tissues. So do they have the capacity to tolerate that load? And we keep adapting to their capacity. So strike pattern's a great example. We might change from a rear foot strike to a forefoot strike to shift load away from the knee and the hip, but it will increase load on the foot and ankle. So possibly it might be a sensible thing to do in the long term, but in some people maybe not the short term, because they don't yet have the capacity to do that. So we need to keep adapting as we go forward. So is there evidence for running retraining, both in general and for patellofemoral pain? We did a mixed methods study, which we published in the British Journal of Sports Medicine, looking at lower limb injuries in general. It's quite a long piece, but it is open access and freely available, so I encourage you to download it. About 6,500 words, so it'll keep you busy for a few hours. but there's a lot of information in there. We summarised and synthesised 49 studies related to running retraining, the majority of which were related to biomechanics. We also incorporated that with expert opinion from 16 people around the world. And what we did is we talked about 10 common conditions that running retraining might be potentially useful for, but of those 10 there's actually only 2 with some evidence. One of those conditions is patellofemoral pain. For those who are really geeky, there's also 10 supplementary files there and more than 150 pages related to interview transcripts and themes, etc. So feel free to have a read of some of those if you feel like it. So what is the evidence? Well, we do have limited evidence in patellofemoral pain that increasing or reducing our hip adduction, so trying to move someone away from that knee valgus position, will help in terms of reducing pain and improving mechanics. So what they did in this study is they used visual and verbal biofeedback, so cues to engage their gluteal muscles and open knees, and visual feedback like watching their graphs from 3D motion analysis in terms of how much hip adduction they got, or using a mirror to help reduce how much knee valgus. So over a 2-week period, they were able to significantly reduce pain, but this was sustained over also a 3-month follow-up. Importantly, they were able to change mechanics that we think are related to patellofemoral pain, including hip adduction and contralateral pelvic drop, and these were sustained 3-month follow-up as well. So 8 sessions over 2 weeks, and then they revised it at 3 months to see if they were sustained. Pain reduction wise, they went from an average of around 5 out of 10 pain to well under 1 out of 10 pain on average. Important thing to consider though, this is a unique population. They were females and they also had more than 20 degrees of hip adduction to start with, so it's probably not going to be applicable for all runners with patellofemoral pain. My anecdotal experience is sometimes when we try and use cues like open knees and just focus on that knee valgus, we can actually overcorrect those mechanics and we can lead to other problems, potentially shifting load more to the medial joint line because we put them in more varus. So what are some other options? More recently, since our review, there was a study published, a randomised controlled trial, looking at running retraining for people with patellofemoral pain, and specifically they had a group of 8 runners where they transitioned their strike pattern from rear foot to forefoot strike, and the other 8 runners that were randomised to control group just continued to do the same running program. So 8 sessions over 2 weeks, but I would suggest it's gait retraining because it's just one component, and that is to change to a forefoot strike pattern. What did they find? So Roper et al. Found that an increase in knee flexion at initial contact, which may be beneficial because potentially that might lead to a reduction in overstride, but also a more favourable position for the patellofemoral joint on impact. And as you would imagine, that by changing strike pattern, the ankle angle at initial contact also changed more from a dorsiflex position towards a plantarflex position. But at the same time, it did shift ankle loading to increase that. So potentially we're changing load away from the knee and shifting it more distally. So were there any adverse effects? Well, from a positive perspective, we had a reduction in pain, and that was sustained over that period. So from an average of 4 out of 10 down to an average of 1 out of 10. So definitely positive from that perspective. From an adverse events perspective, well, firstly, they reported there were no significant adverse events that occurred in either of their groups, so either of those groups of 8 runners. The experimental group reported calf soreness during the retraining phase. So you would expect this for those runners changing to a forefoot strike because they're going to load up their calf, so gastroc soleus a little bit more, and we know from the research that we get higher EMG levels when we transition strike pattern. However, this had subsided by 6 sessions for all of the subjects in the group. What I find interesting is 2 of the experimental group, so those that transitioned to a forefoot strike, actually reported ankle soreness at their 1-month follow-up. So when they were running with their new gait pattern with a more forefoot strike, they actually reported ankle soreness, and they described this as an ache that quickly subsided after they discontinued running. Now this to me sounds very much like patellofemoral pain in the early stages, so I'd be a little bit cautious about this occurring, and I think probably what we're doing is shifting a lot of load, and I'd be very curious to follow these guys over the longer term. So what are some other options? I like to focus more on the sagittal plane because I think it's a lot safer in my clinical practice. Willie et al. Did a nice study where they looked at sagittal plane mechanics and how they might relate to ground reaction forces and also knee joint kinetics, and in particular patellofemoral joint kinetics. What they found is a relationship between lower step rate, landing further from the centre of mass, so an overstride, greater centre of mass vertical excursion, so more bounciness in a running action, and greater ankle dorsiflexion, so toes pointing more towards the sky, were related to higher knee kinetics, so higher loads going through our patellofemoral joint. So these are all things that are quite easy to change with running retraining. There's a lot of research looking at step rate in particular, where we increase step rate by 5 or 10% using metronomes primarily, and this can have a significant reduction in the amount of patellofemoral joint stress and knee joint loads. So if we look at this practically, this is an individual that has exactly what we're talking about, an overstride. He also has high ankle dorsiflexion. So we're getting a lot of increased load going not just through the knee, but through the entire limb. So the cues for this runner in particular is to take shorter, faster steps and think about landing softer. And what we can see is he's gone more towards a midfoot strike, not necessarily a forefoot strike, but also significantly reduced his overstride. So the amount of stress going through his patellofemoral joint is going to be significantly less. And we haven't had to necessarily focus on changing strike pattern or cueing him to open his knees. So if we go back to the runner we saw originally, which some of you may have cringed watching her, if we look at her running, we can see a big overstride, lots of ankle dorsiflexion. And the other thing that you'll notice is that she's actually got a lot of anterior pelvic tilt. What I'll get you guys to do for a second is just stand up. Bill, Kay, Nat, make sure they all do this. So everyone should be standing up by now. And what I want you to do is stick your bottoms out. So I want you to put yourselves in a lot of anterior tilt, like this girl is running. And what I want you to do is try and think about engaging your gluteal muscles. And it's actually quite challenging to do. Second thing I want you to do is tuck your bottom under, so put yourself in relative posterior tilt, and I want you to think about the same thing. And you'll notice that will be significantly easier to engage. So you can sit down again. So the cues we used for this runner, who's got 3 or 4 out of 10 pain on the left side of her patellofemoral pain, we use cues to take shorter, faster steps and land softer. But we also talked about tucking her bottom under as she ran to try and reduce that anterior pelvic tilt. Now her pain in this here is 0 out of 10. Her pain here is around 3 to 4 out of 10 pain. And this is within the same session, so she's able to significantly reduce the amount of pain she's got with running through focusing on sagittal plane mechanics. If we have a look at what that does in the frontal transverse plane, we can see that at baseline she's got excessive hip adduction, internal rotation, pelvic drop. Those of you who want to focus on the foot, we can also see on the left side we see a lot of foot pronation. As we go through, what we can see in terms of posterior view and thinking about frontal transverse plane with our sagittal plane changes, these have led to a reduction in hip adduction and internal rotation, pelvic drop, and also foot pronation. So if we can reduce the stresses occurring in the sagittal plane, we can have a significant implication in what's going on in the frontal transverse plane. And for her, that's had a big impact on her pain. The caution is, does she have the gluteal capacity to tolerate the increase in load there? And does she have the foot and ankle capacity to tolerate the increase in load there that would occur? So take-home messages around running retraining in this very brief presentation related to patellofemoral pain. Manage the risk of our injured runners. So reducing overall load should be a primary focus. So if we can reduce overstride, increase step rate, those types of interventions are going to be more favourable. Improve capacity to attenuate load, so strength and conditioning work. Also potentially neuromotor cues where we get people to think about engaging their gluteal muscles. So we can see this in an individual below. This is at baseline, and this is her running after running retraining and now running pain-free. Interestingly, she'd had 3 or 4 different physios she'd seen, done a lot of strength and conditioning work, but never actually addressed her running mechanics. And surprise, surprise, every time she went back to running, she continued to have pain. And then the third thing for us to think about is, can we shift the load? And is it sensible to do that? So if we shift the load with things like strike pattern, does the individual have that capacity to do it? So most importantly, running retraining can effectively reduce pain, and I think it's something that we often underuse. There are a lot of running retraining options, and we've really only touched on a few today as part of this presentation. So I encourage you to embrace things like step rate and some of the easier things to do. Think really carefully about other things like strike pattern and are you just increasing load elsewhere, and start to learn more and more about this topic. I think that's really important. The other thing is we need to think about the implications on the entire kinetic chain for anything that we change. So even if we change overstride and reduce that, do we have the capacity to do it? Do we have the capacity for our gluteal muscles? And if we change strike pattern, do we have the capacity through our calf? They're just some common examples. Running retraining is definitely not a panacea, and we definitely need to continue to think about all the other things that we know have good evidence base. But in my opinion, it's something that's often very much underused, particularly a lot of the patients that I see clinically have never had their running even analysed, despite the fact that the only time they get pain is during running. So thank you for your attention this morning. Hopefully there's a few little things you can take away to your clinic that might inform some of your practice, both based on research evidence, but also a little bit of anecdote from experts we've interviewed and myself. If you want to learn more about this, please have a look at the running retraining paper published in BJSM. As I said, it's open access and freely available, so it can be downloaded. We also have a blog where there's plenty of research resources on there, and some of them relate to running retraining, so have a look at that and see if you can find some things that might interest you. So that's a sport and exercise medicine research blog, and you'll see the link to that there. You can email me also on my email. The other thing that you might want to do is join our Facebook group, so Latrobe Sport and Exercise Medicine, and on that Facebook group you can pose questions not only to myself but other people within the group, and it's a really nice way of having great discussion. And finally, I will be here later today presenting a poster related to gait retraining, or specifically increasing step rate for people with patellofemoral pain. And that's based on some work of one of my PhD students, Brad Neal, and some of my other colleagues in London. So come by poster number 142 and feel free to ask some questions and have a chat about running retraining in general. So thanks for your time and enjoy the rest of the morning.